This conference will now be recorded.
Welcome in, everybody. Today we're going to be talking about psychiatric emergencies, which is correlated to Chapter 26 in your textbooks. Psychiatric emergency is a relatively common EMS call that we are going to be a part of. However, our treatment plan is relatively limited based on what we can actually do and perform within the EMS setting or the pre-hospital setting. The biggest thing for these emergencies is ensuring that we're safe, our patients are safe, our bystanders are safe, and that we're getting these individuals to the appropriate facility, because there is not a lot of hospitals that actually deal and specialize with psychiatric emergencies. Specifically within the Twin Ports area, we're basically looking at St. Luke's and St. Mary's and Duluth, and that's pretty much it. So let's dive into our case study. EMTs Nancy and Colby respond to assist law enforcement with a person hallucinating. When they arrive, they find a 26-year-old male who is terrified, agitated, and screaming, "Help me, get them off, get these spiders off of me." So when we're looking at that, that's a pretty predominant understanding that this individual is not within their right mind, unless, of course, there is a bunch of spiders on them. But let's dive into it. How should the EMTs approach this patient? What should they say? So first, we need to develop that patient rapport with this individual. "Hi, my name is Corey. I'm a paramedic. What's your name?" And then try and build up that relationship and that trust factor between yourself and your patient. What are some potential causes of the patient's behavior? So it is Chapter 26. We are talking about psychiatric emergencies. This could be a deal of schizophrenia, other related psychiatric emergencies, and then this could also be drug related, which a lot of times with behavioral emergencies within the pre-hospital setting, these psychiatric causes are actually a result of some type of synthetic compound or drug within that patient's system. So, introduction. We cannot always identify and or see a psychiatric issue that's occurring. A lot of individuals who do have psychiatric issues are and or displaying normal signs. They're getting treatment, they're getting medications, and so oftentimes we might not even really identify that this individual does have a specific psychiatric issue. Now, as far as our assessment, very important, the continuation of the care that I mentioned, that we are transporting these patients to the appropriate facility, specifically the facility that they are receiving treatment for, so that we can pull up all their proper records and the appropriate psychiatric team will be treating that patient based on their medical history. So what a psychiatric issue is. Psychiatric disorder is considered an abnormal mental condition. So when we're talking about providing and assessing mental status for psychiatric emergencies or any of our patients, we always want to confirm what their baseline mental status is. So are they alert and oriented, and are they alert and oriented per their norm? Because my mother's got Alzheimer's disease and she's relatively far off. You know, when I assess her and talk to her, obviously she's not going to be alert and oriented in correlation to everybody else in this class. But when I ask her questions and she's responding how she normally does based on her mental condition, then she would be alert and oriented per her normal baseline. So it's very important when we're doing our assessment and then also documenting that we're correlating those factors. Psychiatric emergency is a behavior that is unacceptable in today's society, and that is going to be in corporation with, are they a harm to themselves? Are they a harm to others? Are they a harm to the community as a whole? So this could be a lot of different things as far as the psychiatric role, but the biggest thing is trying to protect themselves and protect everybody around that scene. So behavior changes, oftentimes they can either be classified as psychiatric and or physical based on how that patient is presenting and their medical condition. So always be ready for any type of change within that patient, because they can flip a switch from nonviolent to violent. A lot of different causes can actually cause this behavioral change, and we'll dive into that. So medical conditions, these are the most common ones. Metabolics, we have electrolytes and Cushing's disease. So electrolytes, we need proper potassium, we need proper calcium, we need proper magnesium in order for the brain to work properly. So when we have an electrolyte disturbance, not only is it going to impact the rest of the body system, but it's also going to impact the central nervous system and then the brain and how that patient actually reacts. Electrical causes. So we have discussed seizures as far as epilepsy because we need proper electrical current going through the brain in order for it to work properly. Next, nutritional. So a couple of different deficiencies that can occur. Thiamine deficiency, which is going to be associated with our energy and our B vitamins and our sugar stores as well. Because remember, the brain needs those three things in order to survive. It needs sugar, it needs water, it needs oxygen. And then we could also see anemia. So anemia is going to be low red blood cell count. And as a result of the low red blood cell count, that individual's brain is not getting the proper oxygenation to it. Then drugs, toxins, which is going to be the most common cause of our 911 call for psychiatric emergencies. Could be from street, it could be from medical drugs, it could be from other types of poisonings such as household chemicals. Predominantly, we're going to see it based on street drugs. Specifically, when we're looking at synthetic compounds, so when synthetic marijuana and bath salts were basically the predominant, most popular street drug that was out there, we were seeing a lot of psychiatric emergencies based on those synthetic compounds that were interfering with individuals' ability to act in normal society. And then we could see arterial, which is going to be strokes, and our TIAs, which we covered. Others, mechanical. So a brain injury, subdural hematoma, where we actually have a brain bleed, is going to interfere with that individual's proper ability to assimilate in society. We also see infection. So we have sexually transmitted diseases. We have other types of infections that's going to specifically counteract how that brain actually functions. And specifically, what these diseases are doing is it's increasing the body temperatures so that that brain is not functioning properly. And then also a lot of times the lining of the brain will be affected by these diseases and cause infection and inflammation. So specifically, when we're looking at meningitis, which is a relatively common disease that goes through college dorms every fall, it's inflammation of the brain lining. So the inflammation of that brain lining will actually impede on the brain itself, and it can cause catastrophic emergencies such as psychiatric and then also cardiac arrest. So neoplastic, where we actually have tumors within the brain, obviously self-explanatory. We have a growth that is not recognized by that body system. It continues to grow, and it's going to impede on that brain. And then we have Alzheimer's, Parkinson's, and other degenerative issues that's associated. Alzheimer's disease, what it does, it's a form of dementia, and Alzheimer's, basically the brain shrinks over time, and that's where they start to lose their cognitive ability. Parkinson's, very similar, that brain is degenerating at that point. And then multiple sclerosis, or MS, very similar to Alzheimer's, that brain is basically decomposing at that point. So mental status exam. Again, go through your alert and oriented questions. Do you know what day of the week it is? Do you know what month it is? Do you know who the president is? And then based on those questions, you're starting to dive into what their mental status is, but then also be looking for those environmental clues of your patient. How are they standing? How are they posturing? Do they look violent and agitated? Are they more relaxed? Also, when you're assessing these patients, make sure that you have the proper distance and that you have a proper escape plan in the event that this individual starts to display those violent tendencies. Now, we already talked about this, those different ones. Not quite sure why it went back. Unless I'm hitting the wrong button, which I did. I apologize. There we go. All right, we're back on track, kind of, Sunday morning. So during that assessment too, pay attention to how that individual responds, because again, it could be abnormal behavior, it could be normal behavior based on that patient. So make sure that whoever your lead assessor is paying attention to your patient. And then if you have multiple rescuers and there's bystanders on scene, such as family members or healthcare workers, that individual is diving into what their normal behavior is. Look for skin condition, because mental status changes can be occurred from an individual going into shock, as far as that shunting of that blood, and or it could be a hypoglycemic patient, which predominantly we see diaphoretic skin, pale, cool. Look for posture, gait, unusual movements, and those are going to be oftentimes assimilated to some type of psychiatric emergency. Memory. Again, do you remember what you were doing before this episode occurred? Do you remember what you were doing this morning? What have you? Try and differentiate whether this is acute and or chronic based on, is this Alzheimer's disease or is this some type of psychiatric emergency? And then awareness of surroundings. So awareness of surroundings really plays into the hallucination factor. So within our case study, that individual was complaining that there was spiders all over their body. So if you're seeing that there's not spiders within your scene, be thinking of, is there a hallucination factor that this individual is not actually operating within the current place and time if they're creating that picture within their brain. Body language, again, threatening gestures. So if they're standing, if they're pacing, if they look agitated, if they're clenching their fists, if their muscle rigidity is kind of highly complex, then again, be aware of that this individual is probably throwing a lot of testosterone and adrenaline within their system based on whether it's a male or a female. And based on that, with that adrenaline going through their system, it shunts the blood and their response from the frontal lobe of their brain, which is where we provide reasoning and communication and rationale, to the animal portions of their brain, which is going to be based on survival instincts. So we talked about hallucinations. Again, be on the lookout for social cues, because all of us, when we go to lab, when we interact with each other, we can see that everybody's acting kind of normal behavior. And it's very easy to pinpoint some of those abnormal things, such as repeated words, or staring off into space, or mentioning that something's not there, or they're not able to organize their thoughts, or they repeat themselves. Then look for that mood and affect. So an affect is going to be how that individual reacts based on their current surroundings. Could be rapid shifts within that emotion depending on what's going on around them. So when you are assessing, to try and limit the amount of responders that are within the room, because the more individuals that are actually inside, now this individual has to process more and more information because there's more going on. So try and create a controlled atmosphere when you are assessing these patients. Now, granted, a lot of the times they're going to be severely agitated, so you're going to need law enforcement there. Try and make sure that you're the one assessing the patient and not law enforcement. And nothing to knock law enforcement at all, but they respond to scenes that are much more dynamic, is not the word, but much more scene safety conscientious. So they do have the tendency to rile up these patients just based on their presentation. And then look at their judgment, as far as, do they respond to questions appropriately? Are they saying things that a normal person would respond to based on that current situation? So some clues as far as the physical cause. Sudden onset of symptoms, so that could be our strokes and our TIAs. Memory loss or impairment, is this drugs associated or alcohol associated? Pupillary changes, again, those are going to be based on drugs within the system. Excessive salivation, that can be from a lot of household chemicals and organophosphate poisonings. Incontinence, a lot of times individuals suffering from a seizure will have that, or unusual odors on the breath, and that's going to stem back to our diabetic patients based on the amount of ketones that are actually within their system. So when we're doing our physical exam, pay attention to any type of drug use and or head injuries or trauma-related stuff. And then also when you're conducting that physical exam, look for any type of medications that are around that can provide those environmental clues. So diving deeper into specific psychiatric emergencies, anxiety disorders, a very common EMS call that we're going to go on, which is probably going to be the most as far as psychiatric problems. This is going to be a state of uneasiness. So oftentimes these individuals are still within their right mind, but it is assimilated to panic disorders and or a phobia. So when somebody suffers from a panic attack or an anxiety attack, basically their body throws out all of their adrenaline in their system and it sends them into a fight or flight response based on, it could be nothing or it could be based on a phobia. So let's say somebody has a phobia of confined spaces and they have to take an elevator up and they're in the elevator and it gets stuck and then they have a massive panic attack because that phobia then got triggered. Their body goes into a fight or flight response, so it's going to increase the heart rate, it's going to increase the blood pressure, and it's going to increase the respiratory rate. And when the respiratory rate increases, what we're doing is we're not getting that oxygen all the way into the system because they're breathing too fast and it's in the higher portions of their lobes. And then they're not actually getting that proper carbon dioxide exchange. So I'm exhaling faster and oftentimes I'm blowing off too much carbon dioxide. And as a result, a lot of these individuals will complain about tingling and loss of sensation in their extremities because there's too much carbon dioxide being released. Bipolar disorder, so this is going to be changes from very high to very low. So an individual could be predominantly depressed and then followed up by highs and stages of very high mood swings at that point. So depending on the patient, sometimes those moods last an extended period of time. So when an individual has a manic phase, oftentimes our vital signs are going to show increases, so an increased heart rate, increased blood pressure, could be agitated, could be irritated. When they are in their depressed mood and within depression, oftentimes those vitals are going to be lower because that individual is not clicking along as much as they were during that manic phase. So things we got to be concerned about in the event of a depression phase, oftentimes suicidal ideation is associated with that. Within manic phases, they can be extremely agitated, irritable, and or aggressive and violent. Next, so depression, this is going to be caused by a chemical imbalance within the brain. So oftentimes there's not enough serotonin or dopamine or epinephrine that's going through the brain. And as a result, these individuals are kind of in a continuation of downness, or using the same medical terminology within that realm of depression. What we can see as far as signs and symptoms, we could see crying, we could see withdrawal from society, we could see an increased use of drugs and or alcohol, and then also suicidal ideation and or suicide attempts. Neurocognitive disorders, this is replacing the term for dementia. So dementia basically for a long time has been an umbrella term that has comprised individuals with the loss of cognitive ability, which was their norm. So our Alzheimer's, or Parkinson's. Even urinary tract infections could be considered a form of dementia. But what this is doing is basically that cognitive ability of that individual is starting to depress and decrease. Other forms could be agitated delirium. So this is going to be a neurocognitive disorder. Oftentimes this is going to be associated with drugs, where the drug itself is going to increase the electrical impulses within the brain, and it's also going to increase the body temperature. And it really sends that individual into a state of emergency. As far as psychiatrics go, they're going to be extremely agitated. Most likely they're going to be suffering from hallucinations. They can be very violent to themselves and or bystanders. And then a lot of times this will actually cause that patient to go into cardiac arrest because of how high their heart rate is, how high their blood pressure is, how high their body temperature is, could send that individual into cardiac dysrhythmia and then sending them into cardiac arrest. Schizophrenia, relatively common chronic mental illness. Most of the times, this is going to be controlled based on therapy and medication, so we don't see a lot of patients within the schizophrenia realm. So this is going to be a chronic mental illness. Oftentimes this is seen at a relatively young age, and it's diagnosed, and then that starts to be treated throughout that individual's life. What we can see is delusions, hallucinations, social withdrawal, and then a lack of emotions as far as empathy, and sympathy goes. With these patients, where we actually get called to most common is in the event that somebody suffers from schizophrenia and they have stopped taking their medications, and as a result, they have a mental break associated with their schizophrenia. So they can be very agitated, providing those hallucinations. So they're very similar to that of the agitated delirium when they get to that state. Other issues, paranoia. So paranoia oftentimes caused by hallucinations and or a phobia. So a lot of times they're going to be hypersensitive and argumentative based on what their paranoia is. So a lot of times this is going to be caused by drugs and or some type of psychiatric disorder where they think that the government is out to get them or aliens have arrived, what have you. When you are treating this, try not to dive too deep into their world as far as start talking about, yes, the government is out to get you. Try and bring them back to reality and develop that patient rapport with them. Because a lot of times when you arrive on scene, they are going to assimilate you into their phobia. So if they're terrified that the government is out to get them, they look at you in the uniform, they look at law enforcement in the uniform, and they immediately trigger themselves into thinking that you're a part of the government and you're out to get them. So be honest with them that you are an EMS provider, you're here to help them, and you are on their side. Psychosis, again, correlated to schizophrenia, other psychotic disorders, out of touch with reality. They kind of live off in their own little world. So this could be a danger to society, or this could be simply an individual who just prefers to be alone and live in their own little world. So this could be delusions and hallucinations where we run into an emergency is in the event that they are harmful to themselves and or harmful to individuals outside of them. Substance abuse and addictive disorders, we talked quite a bit about this within the toxicological emergencies chapter, but very common substances. The highest one is going to be alcohol disorders. We could also see caffeine. A lot of individuals are addicted to caffeine and we don't even know it. What we're looking at is individuals who need these substances within their system in order to act or the perception of acting normally. So others, stimulants, marijuana, cocaine, ecstasy, what have you, anybody can basically develop a substance abuse problem depending on what the chemical is. Where we're concerned is in the event that they overdose on those chemicals and or if they start to go through withdrawal symptoms leading to DTs and or cardiac arrest. Trauma, stressor-related disorders, we talked quite a bit about this within EMT wellness as far as PTSD, survivor's guilt. In the event that somebody suffers from a significant trauma and or hardship, they can suffer from post-traumatic stress disorder or other disorders associated with that. A lot of times this will lead to depression and or alcohol misuse or drug misuse. Other disorders as far as psychiatric problems, we talked about this within depression, that the brain needs certain chemicals in order to function properly. And when there is a disruption within those chemicals, they can create that depression or other type of psychiatric problems. Hopefully the warnings and the signs and symptoms are relatively mild so that this individual actually goes in, receives treatment from a registered psychologist, and they get them on the appropriate medications so that those medications start uptaking whatever depletion or increase within those brain chemicals are actually occurring. So violence specifically associated with suicide, a lot of individuals, suicide attempts are based on gender roles. So males tend to be much more violent when it comes to suicide attempts, and as a result, males are much more successful within their suicide attempts. Females, much less violent. Predominantly what they do is overdose on medications, and as a result, their suicide successful completion is not quite as high as males. Now, don't get that in your brain that individuals, when they attempt suicide by prescription overdose or medication overdose, are looking for attention. Most of the time, that's not the case. That it is actually an attempt on suicide. So when you are doing patient assessments on suicide attempts and or individuals who are depressed and have suicidal ideation, what you want to be looking for is risk factors and those potential signs. So one of the biggest risk factors for individuals who are contemplating suicide and who are actually going to attempt it is ask them if they have a plan. If they have a plan of exactly what they want to do as far as attempting suicide, their risk factor is substantially higher than an individual who doesn't have a plan. Other risk factors, individuals who have attempted suicide before. Also a very large factor is, do you have everything in order as far as your finances and your living will and what have you. Violence to others, some of the signs and symptoms that we could see: pacing, and then also that threatening posture, individual who uses cursing substantially, and then also other things that we're very used to as far as individuals throwing, punching, kicking, what have you. Make sure that you're protecting yourself. Let law enforcement go in, trained at this as far as takedowns go, and get that patient into a good position as far as transport. So as far as assessment, for common psychiatric emergencies, provide your mental assessment. Remember, our role is not to diagnose because we can't diagnose in the field. Look for that risk factors as far as violent tendencies and suicidal ideation. And then again, we're still going through our ABCs. We're concerned about immediate life threats. We're concerned about ABCs, and we're concerned about ourselves and that patient. With suicidal ideation, be straightforward and direct. So again, this is not the most comfortable conversation that we're going to have with somebody, whether we ask them, do you have a plan to kill yourself? Have you ever thought about killing yourself? Have you ever attempted to kill yourself? But be straightforward and don't try and step around the bush as far as your questions. So assessing for homicidal ideation, very similar to that of suicidal ideation. What we're going to be looking for is the same questions, only instead of, do you have a plan to hurt yourself? Do you have a plan to hurt others? Need for law enforcement, very important, associated with this, because again, if that individual has to be taken down, we want law enforcement to do that. And then once that actually occurs, then we want to make sure that we are restraining our patient to a backboard and or the stretcher that is safe. So that individual always needs to be restrained in a supine position, not into a prone position. So a disorder that it is characterized by a sadness feeling of guilt, worthlessness, loss of interest in pleasurable activities. So we talked in good detail that anxiety doesn't fit, because this is oftentimes caused by a phobia in which the adrenal gland will send a heavy amounts of adrenaline, and they're going to feel agitated, heart rate's going to be high up. So it's not going to be anxiety. Bipolar disorder, this does fit. However, it does not classify the manic phase of that. Psychosis, oftentimes this is going to be assimilated with hallucinations and doesn't talk about hallucinations at all. So it's going to be depression. So dealing with psychiatric emergencies, we have very basic principles. Every person has the right to proper medical care and has a right to their own feelings. So treat these individuals as you would any other patient. An emotional injury, it's as real as a physical injury. So somebody who's suffering from a psychotic break, let's say somebody who's got PTSD and they kind of swirled down out of control, remember that emotional injury is very real. Cultural differences, they do have a special meaning within behavioral emergencies. Now, when we're looking at our culture differences within the Twin Ports area, I mean, predominantly white, predominantly European descendants, predominantly as far as Catholics and religion goes. Now you get down into the cities, their behavior based on their cultural differences is quite a bit different. So depending on what area you work in, you really want to dive deeper in your knowledge and understanding of the different cultures that are represented within your area. Techniques: approach the patient slowly, make eye contact with that individual, and really listen. These are one of those patients where you actually listen a little bit more than you actually ask those questions to try and build up that patient rapport with that individual. Show signs of empathy, not necessarily sympathy. Remember, empathy is actually understanding. Sympathy is sharing what that individual is going through. Speak calm, maintain that comfortable distance, make sure that we have a proper exit plan or an exit strategy in the event that that patient does become violent. Respond honestly to those patient questions and don't highlight their hallucinations that they may be in. Never lie, never threaten, never give somebody false hope. And then also make sure that if we have bystanders on scene, specifically family members, they can be agitated themselves too. So make sure that we have individuals within our response team that are assisting the family members at that point. So you can see, never leave the patient alone. So any type of psychiatric emergency, we are not going to no-load this patient. We are going to be transporting that patient unless they have an anxiety attack and they start to come down from that. But most psychiatric emergencies, we're going to be providing treatment and transport for that individual. Avoid the use of restraints to the best of our ability. If they're extremely agitated and violent, we do have to use those restraints in order to protect ourselves and protect our patient. However, restraints can cause that individual to be more agitated, and then as a result, they could send themselves into a cardiac dysrhythmia and or cardiac arrest. Don't force the patient to make decisions. Again, that's going to build within that agitation factor. So case study, Kobe kneels down near the patient, sitting on the ground. I'm Kobe, I want to help you, tell me what's going on. Nancy learns from the patient's friend that he has a drinking problem, not able to get alcohol for the past 2 to 3 days, most likely DTs. I've seen it before and it looks like DTs. So what consideration should Kobe and Nancy give to the information received from the patient's friend, and what steps should we take as far as the patient goes? Now, that consideration, that is great information that we have learned from the bystander. That's why it is so important that we are receiving information from bystanders. So he does have an alcohol problem. He has not received alcohol within the last 2 to 3 days. DTs, one of the signs and symptoms are hallucinations or agitation, which that patient is presenting. So then our next steps as far as our assessment goes, be honest with your patient, continue to build up that patient rapport, go through your sample history and pay close attention to, do you have any psychiatric emergencies? Currently taking any medications associated with psychiatric diagnoses? Have you been taking those medications properly? Do you have an issue with alcohol? When was the last time that you drank? Have you ever went into DTs, or have you ever been without an extended period of time of alcohol? And if you have, what did you display? So dealing with those psychiatric emergencies, we talked about this throughout. Make sure that we're conducting a good scene size up, build up our patient rapport, make sure that we got law enforcement there, limit the individuals within your scene. Make sure that we're doing a good head to toe as far as looking for weapons. Ask law enforcement to pat down that patient before you transport them, or even before you assess that patient to see if they have any dangerous weapons on them, such as guns and knives. Be wary of body positioning, and then also creating that exit strategy. So this individual is doing a very nice job of keeping their distance between themselves and that patient. You can see that he's got a dangerous weapon, so he's not even going to enter that scene until we get law enforcement. Don't hesitate to back out even farther. So if I were this rescuer, all right, I get called to, let's say this individual was dispatched for difficulty breathing. I arrive on scene and this is what I see. Immediately radio dispatch, I need law enforcement backup. Individual is holding a weapon, and then retreat to your rig. Your rig is your safety zone. And then wait for law enforcement to arrive and control that scene. Primary assessment, formulating that general impression, going through our ABCs, and then look for immediate life threats. Secondary assessment, go through our sample history and our OPQRST, and then dive into the specific body system that we're thinking that is being affected. So if it's psychiatric, dive into that. If it's drug related, dive into that. If it's epilepsy, dive into that. Suicidal patients, talked about in good detail as far as diving into those assessment questions. Make sure that you're transporting those individuals, anything associated with psychiatric, to the appropriate psychiatric facility. For violent patients, our secondary assessment, if we can, try not to use restraints, but if we have to, restrain them properly so that they are not transporting into a prone position, so that we're not causing asphyxiation from that, but also make sure that you are restraining them into a position that they can't cause substantial movements. Other signs and symptoms: fear, anxiety, confusion, anger, depression, mania. Again, all of these warning signs and symptoms are pointing us to believe that the body system that's being affected is a specific psychiatric emergency. Other signs and symptoms, specifically when we're looking at this is starting to steer us down our depression role and or things associated with alcohol and drugs. So emergency medical care, as mentioned in the first slide, our treatment plan is very, very minimal for these patients. We're going to treat immediate life threats. We're going to treat our ABCs. And what the best thing that we can do for this patient is try and calm them down, build up that patient rapport, and get them to the appropriate facility, because there's not much that we can do. There's not much that the ER staff can do. This individual needs specific specialized treatment from an individual who's trained in psychiatric emergencies, who's trained in pharmacology associated with the specific brain chemicals that are being introduced and associated with that patient's brain. When we do provide treatment and care and we have them on the stretcher, we're transporting, make sure that we're reassessing and make sure that we're reaffirming that we are doing the best thing for this patient at that point. So diving deeper into restraining the patient, only do so if necessary. If we have to do any type of takedown, make sure that we have at least 4 individuals doing so that we can control all 4 extremities and then eventually get those restraints on. Only use if they are specific danger to themselves and or there's a history. Specifically, when I'm saying that there's a history of violence, if you get dispatched to the local jail or the local prison, which is a very common call that you're going to go on, and the prison guards or the jail guards or the sheriffs say he has been out of control very recently, he's taken a number of different swings at us, go ahead and err on the side of caution and restrain that patient. So estimate the range of motions when we are actually doing this. Get as many people as we possibly can. So you might have to call in additional resources before you even make that attempt, and then plan your activities with everybody. After you have made that decision, make sure that you act quickly, approach that patient, at least 4 rescuers, and then secure that patient based on your medical direction. So best case scenario, you're using pre-made splints, or excuse me, pre-made restraints. So you're going to restrain their legs to the stretcher and or the backboard so that they are tight enough that they can't get out of them, but make sure that you're not applying them so tight that you have a loss of circulation. Next thing that you're going to do is you're going to go ahead and restrain their arms. And when, restraining their arms, you're going to have 1 restraint up and 1 restraint down. So as you can see, there's the restraints for the lower legs, and they are tying them to the base of the cot. Be very careful, because you can see what these rescuers are doing is that they are securing that individual to the base of the cot, but that base of the stretcher, we all know, will actually go up to put that patient into the Trendelenburg position. So they're actually doing this wrong. Secure it lower on that handlebar so that that patient can actually bounce up. Next, they're going to secure the patient's arms. And then best practice is you're going to have 1 arm lower so that that arm is down on their side, and then you're going to secure 1 arm that's actually above that patient's head. And what that does is it impedes the individual's ability to actually use their head. So legal considerations, consent, everybody has the right to refuse care unless they are a threat to themselves, a threat to others, they have a psychotic break, and or they have mind-altering substances within their system. Make sure that we get law enforcement involved in the event that we do believe that that individual needs to go, so that we can go through the proper documentation, because we might need to get law enforcement to put a hold on that. So refusal of care, document, 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 and then also get medical direction involved so that we can get that higher level of liability in order to protect ourselves. Using reasonable force, when we are doing this, it's the minimum amount of force that is required, but always have those additional resources readily available in the event that you do not have that minimum force calculated properly. So police medical direction before you restrain that patient. Always seek medical direction if you can, unless they're such a threat to themselves or others that you need to do an immediate takedown. make sure law enforcement is always there with you at that point. False accusations, this can come back to bite you in the butt, and that's why we talked about in extensive detail the proper documentation purposes. So let's conclude this based on our case study. So Colby questions the patient about his perception that spiders are crawling on him. I know you may see and fear spiders, but there aren't any spiders on you, she says. What you are seeing is because of a medical problem. Patient is calmed a little bit by Colby's reassurances, but is still agitated and disoriented. Colby performs a physical exam, obtains baseline vitals and a blood glucose level before transport to the hospital. In the history, she is able to confirm the patient is usually a heavy drinker, but that he has not had a drink for 2 days. Patient denies a history of other medical problems, as well as taking any medications or other drugs en route. Occasionally experiences hallucinations that he is covered in spiders. Well aware of the potential for serious side effects from alcohol withdrawal, Colby reassesses the patient's mental status and vital signs every 15 minutes. This should be done every 5 minutes, even though this individual is considered non-critical. At the hospital, the patient is diagnosed and treated for alcohol withdrawal. He's then admitted to an inpatient psychiatric facility for a completion for an alcohol withdrawal program, which is very important. So our summary, psychiatric emergencies could be a result of a lot of different things. So make sure that we are doing a very good patient assessment when we're diving into sample history. Psychiatric emergency can place an EMT at risk, so make sure that we are utilizing proper scene safety components. Restrain only when necessary, err on the side of caution. Remember our minimum requirements as far as force, good documentation, and remember behavioral emergencies can involve significant legal considerations. And that does it for psychiatric emergencies. Thanks everybody. Have a great day.